often are you finding that the squad brings in a ROSC patient that this is going to go to cath lab?
So I think that the majority of cases, ROSC, will go to cath lab. It's the timing, right? I guess that's it's the timing is always the thing. So again, it goes to etiology, and this is something we've worked on as a system because, again, I mean, some doctors might look at things differently. We've had discussions on this for years in every quality meeting that I sit on because I'm more of a conservative with my approach for ROSC patients. Now, this is universal ROSC, right? I'm not. Right. So, I mean, here, this goes back to, well, what's the etiology of the arrest, right? So, if it's, yes, I'm having chest pressure, I'm hooked up, the squad's there, I have VF, that's a different ROSC, right? And that's going to the lab. Yeah, sure. Then I heard my husband found down for 20 minutes and no pulse, and we don't know. I thought I saw VF, or maybe it was PEA or AC. I mean, and no one knows what the rhythm and things like that. I think that in those scenarios, going to the cath lab is actually harmful. It really, because these, as much as great things that we do sometimes in the cath lab, it's still a very stressful thing to put the patient under. And if you have a patient that is sort of, has had return of their own circulation without interventions, and it's demonstrated stability, us going in there at times can be much worse. So, and there's all kind of things we sort of look at and utilize to sort of see acute when to take the patients to the lab, but I'm much more conservative on if it's not a VF patient, then I think that we really need to think about taking to the lab or not, and I think that that's sort of been demonstrated now through some recent trials that waiting is beneficial to the patient if there's not signs of ongoing ischemia. Yeah. So
and that's cool to hear, because we've heard that before too, that let the patient heal themselves in some cases.
Yep.
A little bit, yeah.
Yeah, no, absolutely, because you can imagine, right? All right, say this is two, then you get sort of so focused on, they're taking him to the cath lab. It has to be cardiac. No. I mean, actually, it could have been a large PE, or it could have been a dissection, or it could just be one of the multiple other causes of cardiac arrest, right? But taking your eyes off that prize, can definitely be harmful to the patient sometimes.
And we often will bring, when we do bring ROSC patients to the lab, there's multiple times when there's normal coronaries and there is no cardiac etiology. Yeah. So now we're back to square one. All right, let's figure it out again. Electrolytes, sepsis, what
you can push them out.
PE.
I know what it's not.
Yeah. Right.
Yep.
Right. So you had mentioned earlier that sometimes it's better to go into the wrist for these procedures, and it's easier to keep the bleeding down. What determines where you and why would you go to the wrist as opposed to maybe a femoral artery? Or
over the last 10 to 15 years, I think that there's been much more push to radial approach. Standard, going up from the arm has been around for a long time, and then they first started doing it, it was brachial cut downs and things like that. But then it sort of transitioned, coronary angiography transitioned to a femoral procedure for many, 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 many years. Until, over the last 20 years, though, I think that there has been more of a push to do a radial approach in general. It's harder on the operator, but once you do radial approach, then that becomes minimal.
Nature, sure.
It's funny for him to say that, because when he trained as primarily a femoral guy, and then he transitioned probably in the last 7 years, probably.
Yeah, I think early on, but it was when I think it became the writing on the wall. You better be a radial artery operator in some fashion. But the benefit of it is really reduced risk of bleeding. Okay, so I think that there's been some trials looking at radial versus femoral and STEMI. And the first trial they did, was actually, we were shocked that like there was equipoise, but I don't think they set the trial up as well. And so in some analysis,
wasn't well engineered in.
But then subsequent trials have demonstrated that there is reduced bleeding risk for sure, and this is the main complication that we always worry about in any STEMI and PCI. We just sat there and talked about how we're going to pound them with aspirin, Brilinta, and heparin. Now let's. How are we safely going to get into a vessel, right? And
without bloodletting.
Get into an artery,
right. So I think that, but when you're deciding in a STEMI, scenario, so I think that the first thing I always, the questions you have to ask are, as a patient in a prior coronary bypass graft. So, that's usually more of a scenario where we will do femoral, because it's hard to reach all the grafts from the arm. Now, we can do there, and, in an elective setting, sometimes if we can snake our way over to the left subclavian so we can inject a lima and things like that. But in a STEMI setting, I think if you've had cabbage, femoral is a way to go. I think also patients who are in a shock state, in case we're thinking of needing some advanced support, because
you can put a bigger
you're sort of there in the femoral artery, and there's different approaches to looking at the shock. Are you going to do it Impella or balloon pump, and the timing of putting in an Impella or a balloon pump. Do you do that first or after the PCI?
After the
there's
PCI,
there's actually a really large trial that UH is a very active participant in right now, involving an Impella device and unloading the ventricle before doing PCI. So it's patients who have big anterior MIs and in shock, and is putting an Impella in for 30 minutes. Rather than revasking right away, because there's a lot of thought that this could be. So this is these are things that are coming down the pipeline. So we're involved in those trials and things like that. But when you're talking about access, that's a thing. But so those are the two, I think, main settings where you would do femoral first. I think that sometimes smaller patients, especially maybe smaller women, just because of the size of their artery, would be a third scenario where, you would think femoral first. But I think that all other cases, we're thinking radial first, mostly for bleeding risk minimalization.
And you guys know from your trauma training, you can lose a liter or two in your leg, or even retroperitoneal. You can lose a ton of blood before you start getting symptomatic.
Absolutely.
And here we know from experience, if a guy starts getting 50 cc's in this little area, he's going to be jumping off the table.
Right. Yeah.
So it's really easy
across the room. Right.
Really easy to see when it's bleeding in the wrist. Not so easy to see when it's in the femoral.
Point. Yeah. So let me throw a crazy scenario at you. You have a multi-systems trauma patient, comes in with a STEMI, maybe infections here, you can't get through it. Can you cannulate from any vessel?
I think that, transcarotid coronary angiography is frowned upon in the United States. But it is a great question, and these cases happen. Even a better scenario, right, is there be occluded, a vascular path. We've all had these nightmarish cases where, you can have an occluded abdominal aorta, and you've built bypass around, and then you have twists and turns up here. So, I think so. Cathing from anywhere. Obviously there needs to be a radial or a arterial conduit to go through, but certainly brachial, radial, femoral are our safest conduits to get there. I don't think anyone would. I guess, if we were asking brachial, I don't think anyone would stick a brachial artery. But in obviously these would be extreme, scenarios.
Yeah.
But certainly we find ways to, get to where we need to be.
Get where you need to go.
Get to where we need to go for sure.
And why do you always prioritize right? because every example you it was always like
Yes.
same with you, right?
Yeah.
So I can, yeah.
Go ahead.
Well, it's no good. It's the table. It's how the table's set up, actually.
There it is.
So, so that is the thing. The universal cath lab table is us standing on the right side of the patient. Now, it's a great question. So we were saying with cabbage before. So a lot of times there are some people who will be left, radial operators. Now in STEMI, that's a little challenging trying to pull them over. But certainly when they're laying on a table, and if you have your hands here and you can put it, it's equivocal to, being on the left femoral place if you can set it up right. So we can use the left side certainly as well.
Can be done.
And it's actually it's actually a little easier and hypothetically than the right because the catheters are made, to go take that natural track
around,
like this,
Yep.
And it's hilarious that the classic textbook on cardiac catheterization is written by a guy named Don Bain, and I had the privilege of actually training under guys who trained under him. So Dr. Cunningham, he always, when I was a fellow, he'd always say, did you read Bain's book? And I was like, what are you talking about? I'd always hear him alluding to the line. It's the left coronary catheter is meant to land in the artery unless inhibited by the operator. And I always thought that was the greatest, fellow bust chops line in the universe. Listen, if you can't get that in there, it's you're not doing it. So so hypothetically, left should be better than right. But
Is there ever a scenario that you might have to crack a chest?
No, not as an interventional cardiologist, but I think that certainly in the cascade of our team, yes. Are we going to do that in the cath lab? Of course not. But I think as we see our higher risks and our shock programs escalate, what is wonderful is in a broad system like this, we have. Just the highest technologies available, and we're looking at doing ECMO, in cath labs and things like that, and we do this, and it's crazy to think about. If you would have said 10 years ago that interventional cardiologists are going to be cannulating for ECMO, it's amazing.
Yeah, I was really amazed by some of the names you said that were coming into your team now, and what you're doing at Geauga Hospital. Even it's just, you're doing almost everything downtown's doing, except I think one thing. Was it?
So the way our program is set up, there's 3 different level cath labs in the state of Ohio. So we're a level 3 cath lab, and that allows us to do elective PCI, which is stenting, and emergency PCIs. And then some programs, and our program does not have open heart surgery on site. But we have the ability to, do what we need to do, save your life in a STEMI, and then if you need to, we could transport you where you can get open heart.
Main center. So
the programs that do have open heart, they're a little bit higher. They're the next level up of cath lab. So that would be, in our system, it would be Ahuja, Elyria, and main campus CMC. So, but in the majority of the STEMI cases that we take care of, we have everything we need at Geauga.
Right.
And when you leave the cath lab at Geauga, as with all of our system programs, you have general cardiology, you have interventional cardiology, you have heart failure, you have electrophysiology. If you need a pacemaker, you need a defibrillator, we can do everything there. The only thing we can't do is open heart. Yeah. But Dr. Stefano works well with the guys at Ahuja. He works well with the guys at CMC. He knows the surgeons to call. It's really seamless. Yeah, it's really seamless.
We just sort of transitioned our Samaritan lab, to a level 2 downtown, or down south.
Down south.
This Dr. Dallin is started out there and going to really beef that lab up. So they did their first elective PCI case on December 7th after a lot of work. What we've really done in the system is say, listen, we're going to give care locally, and that includes emergent care and sort of what Jeff was saying, like, a cath lab at Geauga, cath lab at Portage, cath lab at Lake West and Elyria. They look just like the same. They're exactly the same brick and mortar with exactly the same, fun toys and tools and equipment to get things done. The only difference between some of the centers is the bypass surgery program. But we know that, and we were part of the trial at Geauga, the Seaport trial, that it does not matter where you get your index case, and it's actually better to just go to the first place. It's not, I need to go somewhere where they have. I mean, that's if you were the 1 in 100 case that needs that, then we'll take care of that down the line. But I think that strategy and structure is really, has helped a lot of people throughout Northeast Ohio, in these systems.
Well, it very much follows the trauma model of care. It used to be, the golden hour. You got to get the guy to the trauma center, get the guy to the trauma center. And then they made the Ohio trauma law, which said closest, most appropriate center. And the same thing holds with all the hospitals. We try to get the patients wherever they can get PCI the quickest. And if we need to transport the patient or support the patient, we're able to do that.
Real quick, you spoke a fair amount about Impella. Again, if you're not working the transport side of EMS, they're probably pretty blind to what Impella does. So you can just explain how that cardiac support works.
Absolutely. So, the Impella is a device that it's an axial pump that it looks like a little hook, and basically is placed the majority of time through the femoral access. Sometimes there are axillary approaches and things like that, and patients who have really a tough vasculature, but the majority of the time it's it's going up at a femoral approach, and you're going up over the aorta and putting a pump in the left ventricle.
Pump on a wire,
and it basically circulates your cardiac reserve, depending on the size of the pump we put in. I mean, some of these can now provide up to over 5 liters of support.
Right. Wow.
The standard, you're usually getting about 2.5 liters of extra, normal, but that's more than half of normal in general. Right. So basically, the thought process is okay, there's cardiac or cardiogenic shock, right? And then basically that's from heart not squeezing blood.
Right.
So what can you do to help get that done?
Augment that,
And putting this device in not only augments that the pressures and does the work, but that unloading of the ventricle lets it relax and rest. And I think that's a bigger mechanistic piece that we're still learning about. But it'll be really interesting to see how that plays a role. But so a lot of times this device has helped a lot of patients for certain who need it.
Day in the life. If nobody's ever, if a viewer out there has never had the opportunity, and let's take this sidetrack for a second. If they want to come and observe the cath lab, you guys have an observer program. You want to speak to that a little bit?
We do. We've had an observer program for probably the last 10 years. And kind of the way our cath lab functions is we always have students in the lab. Dr. Stefano came from a program where there were students, and Geauga in particular has turned into a teaching facility. So we always welcome people to come in. There's always a nursing student. There's always an EMS
medic
student.
Yeah.
So if you're in EMS or in a medical profession and you're 18 years or older, all you have to do is contact us, and we'll get you into the lab to observe for the day.
And we'll put all your contact information in the show notes.
Absolutely.
So they know how to get a hold of you.
Yep.
Now, on to my original.
No, but certain. I mean, I encourage anyone who wants to do that. We would love people to come watch.
Yeah,
I mean, that's for sure.
Years ago, I think I brought a case in that you even came out and said, "You guys want to come watch this?" And we were with the fire department. And we were like, "Yeah, why not?"
Yeah.
It keeps us out of work for a few more minutes. So we went and watched, and it was amazing.
Yep.
So this isn't new. I guess that was 10 years ago, probably. So right about.
Well, now the next time you take care of a patient,
you know where
you know what
right.
to tell them what's going to happen.
Correct.
It's night and day.
Yeah. So, for those who have not had that experience or don't wind up taking you up on the set offer, what what's the whole cascade? How does it shake out? From the time they walk through the door, let's say it's optimal conditions during the day, they're not stalling for a minute while we're calling you guys in after hours. During the day, they've pre-activated a STEMI. How does that look from essentially the doors to completion of the procedure?
So we've got a patient that's been pre-activated. So
it's the real deal.
What's happening behind the scenes is Dr. Stefano is waking up and scratching his head and looking at his pager, and then what he does is he calls the emergency room, and he'll call and talk to the attending and get the attending to the attending report. So the doc in the ER talks to the cardiologist, and he says, "What do you got?" He says, "I got a 55-year-old with ST elevations, left arm pain." And, did you send me the EKG? Oh, I see the EKG. So he's looking on his phone and looking at the 12 lead that you guys transmitted. And typically what happens is they sort of give each other the high sign and say, okay, we'll bring the team in. So the team on the other end, and I'll get to that in a minute, he'll say that we're going to bring this patient to the lab. Go ahead, give the protocol meds, which 9 times out of 10, the squad or the ER have already done. So the aspirin, the Brilinta, the heparin, we get an IV in the left arm, if at all possible. And I say left arm because remember we're going to use the right wrist most of the time. So we bring the patient to the lab, and what's happening also behind the scenes is there's 3 cath lab staff that are calling the ER to say, I got the page, I'm heading in. So all 3 of them, 2 nurses and an x-ray tech, are going to be coming in behind the scenes. So that's a way that we confirm the whole team has been notified and that we're coming in. So as soon as the team gets there, they go to the lab, they fire all the equipment up, open the table up, and when 2 staff members are here, we'll head over to the emergency room and bring the patient over. We always put the patient on fast patches because those are the patients most likely to go into VFVT. So inevitably, you'll move the patient over and you'll be in the middle of the hallway, and something bad will happen. Yeah.
So Jeff, let me sort of jump in too. I mean, I think just to fill the, we had cases too where it doesn't even necessarily have to be an ECG transmission. I mean, it's like they have Chardon called, they have a STEMI, they hit the ER doc will activate this team, and that is a universal yes and no questions asked again kind of thing that we go to. So I mean that team activation will start. It doesn't even have to have the EKG transmitted.
Right.
Of course. Helpful and optimal, yes. Yeah. But I do, so sort of the one thing I think from an EMS perspective, though, with this is sort of, it's all timing and things, right? So at 2 a.m., right, we're at home and, we're sort of coming in to do this, right? So that's where it's sort of like when you hear a direct to lab or not, direct, because it might be like, well, why sometimes they take them, we take everybody directly to the lab if we could. Sure. I mean, so obviously, that piece of it, but I actually had somebody ask me one time and it's, that makes sense. Why would do it
that's why I'm kind of asking.
You might have to wash the soap out of your hair before you get there.
Right, exactly. So go ahead, Jeff. Sorry.
Right, Jeff.
Yeah. So once the cath lab, once at least 2 of the cath lab members are there, we'll start bringing them over to the lab. So usually I Shanghai one of the medics like your brother and have them come over to the lab and help us load the patient over. We get the patient over to the lab table, we prep the groins, we get the wrist ready, and by that time Dr. Stefano's all gowned up and scrubbed up and ready to go. So typically what he does is we'll give the patient a little bit of fentanyl, a little bit of Versed, a little twilight sedation, and then we're going to go into the wrist. We're going to numb the wrist up with 1 or 2% lidocaine and then go into the radial artery. We pass a sheath into there, which is a big long IV that we can exchange catheters. The catheters go all the way up, and if we suspect that it's like a 2-3 AVF ST elevation, so we suspect the RCA, what we typically will do is we'll take a quick look at the left. So the side that we least suspect, and we're kind of looking to make sure, hey, there's no funky like left main disease or multivessel disease or anything weird. And then once we've taken a quick shot of the left, we go right to the right coronary and start fixing things. So then what Dr. Stefano will do is, once he has his guiding catheter in there, the guiding catheter is the one that has a little bit bigger inner diameter, and he can pass wires, tubes, and catheters through the inside of that. So he'll pass an 0.14 hundredths of an inch, it's about a human hair size, wire through the blockage, and then get distal to the blockage. And then what he does is, when he gets distal to the blockage or pokes through the blockage, he'll advance a balloon. So the balloon kind of rides on like a monorail, and it slides right down the wire, interventional wire, to the lesion, and then he inflates the balloon, moves the plaque out of the way, and then takes the balloon out. Yep. Now, if he would leave that alone, back in the 80s we used to do that, that would narrow back up.
Just collapse down
a couple months or sooner. But then we would go ahead and put a stent in. So same way that you put the balloon in, the stent goes in, and the stent basically sits crunched up on top of a balloon. And when you inflate the balloon, the stent struts lock out. And then you deflate the balloon, take the balloon out, and the stent stays there.
Scaffolding the vessel.
The scaffolding stays.
And from start to finish.
And then if he's a perfectionist and he says, that's good, but I want it to be better. So if he used a 3.5 stent and he wants it to get 3.75, we've got special high pressure balloons that we can insert to get. So what we want to do is we want that vessel to match the internal diameter.
Yeah.
Exactly.
Straight across.
We don't want it to look like you swallowed a piece of candy and stick it on your neck.
Yep.
So, because what happens is if you don't have a good match of the stent, you get little pools of like little potential spots of clots to develop, like little eddies in the river.
Turbulence, yeah.
So we want it to be smooth, and we want it to match healthy tissue across diseased tissue into healthy tissue is where we want to land it. And then when all is said and done, you're going to stay overnight typically. You'll get the sheath pulled out of your arm. You get a radial band. Usually 1 to 2 days and you're out. But that's the fast and furious version of the cath lab.
Yeah, and from the time you hit the cath doors till you exit, how much time are we talking? 8 hours? 8 minutes?
Yeah. So we, on a routine cath, we tell our patients an hour.
Yeah. It's,
I would say in a STEMI, it can be faster.
I mean, it's usually faster
unless
in a
it's a crazy case.
Yeah, no, I think most acute MIs, we know that it's best to get in and actually fix the culprit vessel. A lot of times, as Jeff was saying, like if we think it's going to be a right coronary artery, infarct-related artery, you shoot the left system. Well, sometimes there's, a 90% prox LAD lesion.
Sure.
And you're like, oh my God, what am I going to do about this?
Yeah.
So then there's been a lot of controversy on what to do about that vessel, and that's actually sort of sorted itself out. But we know in the acute setting that it's usually get the infarct-related artery open first, let things cool down, and then come back and do anything else needed in that scenario. So I think in most STEMI scenarios, not complicated by shock.
Right.
That you can say it's going to be a half-hour case. However, if this is a STEMI that's complicated by shock, then you're going to, now this is when we're talking about putting in, support devices like Impella, and these turn into the, protracted cases.
Sure.
But, I do think it is something, I think when we're talking about education, if we're talking about time and Impellas and things like this, I think a key thing too is like symptom onset, right? Like, I think as we continue to sort of educate all of our providers who take care of these patients, right? If it's, listen, I was totally fine yesterday. I ran 3 miles. Yep. I haven't had anything. I had chest pressure 15 minutes ago. Okay. I love that, right? That is a clean, acute event versus it's I had chest pain 3 days. I had crushing chest pain 3 days ago.
Heavy the turkey.
And then I didn't feel good, and now I can't breathe, and these late shock kind of cases. And these are, I think,
muddy,
and this is what you see too. And these are the sort of sorted out kind of cases that. it's like, okay, yes, there's some ST elevations, but it's the devil's in the details. And these guys had their infarct 4 days ago, or are now coming in like cardiogenic shock because of being in heart failure and things like these. So these are, I think, the cases that are much more troublesome, or they're harder cases. That's just the bottom line. So I think that though. Trying to think about that from all personnel standpoint, like what are we really, trying to do here for the patient?
So we've said a couple times you're going to go in and take a look. Yeah. How do you look inside that vessel?
Great question. Great question. So it's actually X-ray. Yeah. Okay. So what it is, it's a multiplane X-ray, and what we're doing is we place a catheter, as Jeff was saying, so we run a tube up right into the arteries. So when you have, as we all learn, we have left main and a right coronary, sort of off the right coronary cusp and the left coronary cusp, and then they split into different vessels. So we put the catheter very gently directly into these vessels, and making sure we're not causing trauma to the vessels, and we inject dye, and then simultaneously we're taking an X-ray picture in real time. So you're actually seeing X-ray on a screen, and then you'll see the dye go through through the blood vessels, and then we usually give up to 10 cc's of contrast in these injections. So when that sort of runs out, then the picture goes away in that view. But we take different views, so we're seeing the vessel at all angles. There's sort of 4 standard pictures that we take to make sure we're covering all angles and seeing, again, every view of the heart, so we're not missing anything.
Anything else, guys? Everything. We've done a really good job of everything on the list here, to be quite honest with you. So, any parting thoughts or anything that's?
Can EMS do anything better?
Yeah.
I think you guys are doing a bang-up job. You guys are sort of the recipe to our success, and I think it's the same way throughout the system. You guys are being very proactive. You guys are doing things that are at the cutting edge. Yeah. I would say keep on keeping on. Keep on doing what you're doing.
Yes, our majority of successes, I think, at Geauga. We've built the HVI around the STEMI program at Geauga. To be honest with you, and it's an amazing program, but it's driven by EMS. It is. It is because of these STEMI activations. We are always first or second, in the, when we look at our numbers throughout the system in terms of timing, door to balloon times. And we're in Geauga County where people are living far away, coming in, and we're getting this big drop net of patients. And, quite frankly, as, systems evolve, right? This is going to just be how it goes forward, right? It's always, it's better forward. What's the next thing?
What's the next thing?
And just, I got to tell you, the education and just the quality of the EMS, within UH is just, it's top notch. Really, that's not lip service. That's real. Right. That's the real deal. And I think, personally, I've seen it with our program that, our STEMI program is Jeff and mine's baby. It really is a job. That's, if you said, what is our,
what do you love to do?
Yeah. And it's really, the results are what they are because of, EMS and you guys and everybody, the whole team. And that means a lot to us. And that's why we want to be, available to help in any way and things like that, and continue to, educate and help everybody going forward.
Yeah, and conversely, it says a lot about the docs and the nurses and the rest of UH that are willing to come here on a random Monday night when it's snowing. We may be staying the night here with as much as it's snowing, to get this education out to EMS. And we're very fortunate in this region that we have so much buy-in to the pre-hospital care. And
I can't speak for you because you're a little older than me, but I can personally say I've been in the EMS system with Geauga for 20 years now, and to watch what you guys have built has just been phenomenal. And I just, like I said, in another 15, 10 years from now, what else is it going to be?
Yeah,
It's
what's
cool.
the next thing? Yeah,
But I
look
think,
forward to it.
I think it's important too, though. Like when you have this kind of stuff, and if you're right, I think the feedback is bi-directional, right? I mean, it's always, and it is like, hey, why don't we do this? Why don't I mean? And I think that sometimes the littlest ideas, like if you're, a new EMS person, and you think of something like, what about that? I mean. Throw it out there.
Regularly, I get an
mean,
email from Jeff, and it's, this is what squads are doing good, relay this information, and that works out really well. And that always goes both ways, too, where it's like, awesome. The squad didn't like this when they came in. Maybe you can, and it's been great. So.
Yep. No, absolutely.
Well, as a token of our appreciation for you coming on this snowy Monday night and sitting with us, we
always have a little
we have a
little parting gift. You don't get any more though.
Some challenge coins.
Thank you, sir.
No, thank you. There's
awesome, guys. Thank you.
Limited cash value.
Right now, we'll see.
It might get you a half a beer somewhere.
So do you know the tradition of the challenge coin? So this is something they do in the military.
Yep.
If you carry this around with you,
We
or
expect you to
somebody
do
else
that
carries it
24/7.
around and they smack this on the table and you don't have a challenge coin on you, you're buying the beers.
Buying the beer.
All right. Well, that's easy to know where this is going to go. My pocket, not very far. So, especially with this group of derelicts, sometimes that you run around with.
Yeah. So, guys, hey, thank you so much for visiting, and it's been a great talk.
Yeah, thanks, guys.
Thank you.
Appreciate it.
All right.